Sorry, guys. Okay. So the guidelines I used, again, like we discussed, I did the standards of medical care in the diabetes, and that's updated from 2019. I also looked at guidelines from the ACE and the Endocrine Society. So the ADA defines hypoglycemia as 3 different levels. So a level 1 is between 54 and 70. A level 2 is less than 54, and level 3 is something more severe, where the patient has some altered mental state and physical status, and they require assistance from somebody else. So we know in our practice, some people are symptomatic and some are not. We know that this can progress to very severe problems, including loss of consciousness. They can have seizures, they can go into a coma, they can have death from hypoglycemia. So older adults with type 2 and a history of severe hypoglycemia, in some of the studies, it was shown to be associated with a greater risk of dementia. And then in the 2 well-known trials, the Accord and Advanced trials, severe low sugars was associated with increased mortality. So knowing all this, as a provider, we just have to be very vigilant in making our goals for patients goals that they can attain safely. So you may not want to aggressively treat somebody to get their A1C, say, at 6.5 or 7%, if it's at the risk of them being hypoglycemic. So risks for lows, of course, is being on insulin or secretagogues, and if you're taking those in excess, if you're taking them at the wrong time or too much, or even the wrong type of insulin regimen. Patients who miss meals or in a fasting state, if they don't have enough glucose to utilize, such as an exercise, longer duration of diabetes, the frail, the elderly, patients on multiple drugs. I put in there beta blockers because beta blockers can mask symptoms of hypoglycemia, so just be aware of that. Alcohol can also decrease the endogenous glucose. If you're more sensitive to insulin, maybe if you're losing weight or regular exercise, or you've just really improved your glycemic control, and then we need to reduce those doses. If your insulin clearance is reduced in things like renal impairment, if patients are cognitively or physically impaired, and those who have hypoglycemia unawareness. So other things that either can cause or contribute to hypoglycemia, things like adrenal insufficiency, insulinomas, of course the renal disease, patients with gastroparesis, gastric surgery, critically ill patients, and also patients that accidentally mix up their insulin. So if they're an elderly person, maybe can't see very well, or maybe a little bit confused even, they may actually replace their basals with their boluses, and then they end up with hypoglycemic events in the middle of the night. So there's lots of signs and symptoms of hypoglycemia. Most of you are probably aware of the variety of symptoms that can occur. I mean, it can be anywhere from being anxious or nervous or irritable. It can cause confusion. You can get lightheaded. You can feel hungry or nauseous. You can get weak. You feel sleepy, headaches, just kind of cognitive issues, and of course, heart racing, tremors, those kinds of symptoms. So as our job as providers, we first have to be the detective. So one is that you want to determine the cause of the lows by looking at their med list, looking at their behaviors, and thinking about any other contributing factors. But also, we want to prevent another episode. So we want to make sure we're educating them on recognizing lows, the treating of lows, and prevention, and also making sure we're following up with those. So when you're looking at the medications, just think about, is it prescriber or user error? So we all, can sometimes make mistakes, or maybe we just need to change the way we're giving the insulin, but we want to first think about, what is your target? So do you want to improve fasting, pre-meal, post-meal, middle of the night blood sugars? So based upon what your goals or targets are, that will give you an idea of which insulins to change and how to manage it. And you want to know, of course, how your meds work, and in combination with other medications. And then, of course, we want to teach our patients how to properly administer the meds, how to monitor the adjustments and, make those adjustments based on the response to the therapy. So the user error, of course, a lot of times we see, they're not taking it correctly. So we have to, ask them specifically, tell me how you take this, what time of the day, in respect to meals, in respect to activity. A lot of times patients tend to overtreat. If they're either the doses just need to be reduced, they're on too much, or if they don't make adjustments based on their intake or their activity levels. And sometimes patients really want to get their sugars down and they'll take their doses before they're actually due, and we call that stacking. So they have one dose in, and then they take another dose shortly after, and so eventually those insulins kind of stack on each other and then they get low from that. Okay, so the diabetic drugs that actually do not cause hypoglycemia, I think I might have missed a slide, hang on one second. Nope, I didn't. So your biguanide, so that's like your metformin, TZDs, the GLP-1 agonists, the DPP-4 inhibitors, your alpha-glucosidase inhibitors, and your SGLT2 inhibitors. So I will say though, sometimes if you start a patient on one of these agents and they're already on insulin, and then all of a sudden they're getting low, it's not that actual med, it's just that the meds are helping improve sugars, so the requirements for insulin will go down. So you just have to make sure you're explaining to them it's not that actual oral we're giving, it's just that they're now more controlled and we have to adjust therapy to account for that. So insulin, of course, these are the drugs that cause hypoglycemia, your sulfonylurea secretagogues, and then the non-sulfonylurea secretagogues. So when you look at the behavior changes for patients, the ADA, they do recommend 150 minutes of exercise a week, spread out over at least 3 days, with no more than 2 days in between. So, exercise can be different for every patient. Some respond really well, some get hypoglycemic, some don't. And, if they're using an activity that's more intense, like running or jogging or training for marathons, it's going to have different effects on the patient. So as a general rule, if pre-exercise their sugars are less than 90, they may actually need to pre-treat with a carbohydrate. And they may need to also do it during the activity and after, because we know that, hypoglycemia can occur hours after the activity. If it's a higher intensity activity, you actually may need more than 15 grams of carbs to start. And for me, it's not any great rule. It's basically trial and error. You tell them to try this. If that's not enough, you give more carbohydrate pre-exercise. And also you can adjust their dosing. So if they're someone who has a known regimen, they're going to exercise every single day after lunch, they're getting low, after that activity, you can actually reduce their doses on the meals prior or the oral agents prior to their activity. Or if they're on an insulin pump, you can suspend the pump prior to the activity. And of course, you want to make sure they're frequently monitoring during the activity. So as far as intake, patients who reduce their carbs with meals or eat a higher fat content meal, waiting too long between meals, skipping meals, those are all behavioral changes we can address at the visit. And we want to make sure they're prepared. So they need to have available, simple, and complex carbs at all times to them. So alcohol is another thing sometimes we forget to talk about with patients. Oops, sorry, I skipped a slide. Alcohol can block the production of glucose in the liver, which the liver contains, emergency stores of sugar that helps raise it if it drops too low. So if you have a patient who has frequent lows and they've lost those extra stores of sugar, it's going to take a lot of time to get that sugar back up. So you have to just be very careful with alcohol use. So women, they recommend no more than 1 drink of alcohol per day, men 2 drinks. These are the listed alcoholic beverages for normal sizes. Of course, they don't want to drink on an empty stomach or when the sugars are low. Do not skip a meal if they're going to drink. Often the insulin dose needs to be reduced if they're planning on having more than 1 drink. You want to make sure if they're in an environment where alcohol is used, that they have their medical alert ID, because they could be mistaken for having, being drunk rather than just having a low sugar based upon their response and how they act. And then of course the craft beers, which are pretty popular now, just to make sure it does have twice the amount of alcohol and calories as light beer. So of course, no driving for several hours after drinking. And as I mentioned before, hypoglycemia can either occur like right after drinking and for up to 24 hours of drinking. So make sure they're checking before drinking, while drinking, before they go to bed, and throughout the night, and more often up to 24 hours afterwards. So before going to bed, I would say try to keep their sugars between 100 and 140. But if it's lower than that, then they definitely want to eat something and make sure they repeat their blood sugars prior to going to sleep. So treatment of hypoglycemia, we have something called 15-15 method. So 15 grams of carbs will increase the sugar by 15 milligrams per deciliter for about 15 minutes. So if a patient's sugar is less than 70, you're going to treat that with a simple carb. And in 15 minutes, you're repeating the blood sugar. And if it's still low, you're going to repeat that whole process over until the sugars are over 70. So once you get it over 70, the next thing to do is if it's within an hour, they can go ahead and eat their meal that's coming, the next meal. But if it's going to be longer than an hour, they shouldn't wait. They should eat a complex carb to keep their sugars maintained, and of course check more. So simple carbs, this includes things like glucose tabs. They can take anywhere from 3 to 5. You just have to read the label, because usually I think one tab is 5 grams of carbs roughly, Sheree? You're supposed to take 4. Okay, so it's 3 or 4. You can get the glucose gel. You can do 4 to 6 ounces of regular juice or regular sugar. Regular juice or regular soda. A tablespoon of sugar, honey, or corn syrup. Non-fat milk, about 8 ounces, and of course, hard candy. So make sure though they read those labels, because sometimes Lifesavers, it's like 6 or 8 of them. It's not just one. So you just have to make sure you're looking at labels. We also have glucagon. So glucagon is an emergency treatment for severe hypoglycemia. The patients who are at high risk should have a prescription for this on hand. And it's given as an injection in patients who basically are not aware enough to eat or drink. You never want them to be forced to eat or drink. They could hurt themselves or aspirate. So if they're in this situation, you want to make sure you're giving a milligram, IM or sub-Q. And of course, most times they're calling the ambulance by that time. They need to follow it up with oral intake, because it works quickly, but it's also gone quickly. And then the one thing patients never seem to do is they never call us and tell us they how to use it. So for me, that's a very big problem. Being that hypoglycemic and not letting your provider know is a bit concerning. So there is an expiration date on the kit, so just make sure they check that. And then if you have them in your clinic and they're with a family or friend, I would definitely have them educated on the pen, because they actually have to mix it. And so if they happen to get into that situation, they're very nervous. So they may actually not know what to do. And then I would have them demo the pen. Can you guys see me? Can you see what I'm holding up? Anybody?
Probably have to go back to.
Okay.
I usually go up to the screen.
Let me just show you. This is what the kit looks like.
You just hold it right in front of that. There you go.
Can you see that?
Yeah.
It's not a very good picture. I'll show you another picture, but that's sort of what the kit looks like. But I tell patients, keep one in your home, know where it is, have your family members know where it's kept. I would keep one at work, and your coworkers should know where it's kept, how to use it, that kind of thing. And they're not cheap either. Sometimes patients won't even get the prescription filled because it's just very expensive. Some insurances, Sheree, can you speak to that of cost?
I think it's about $600 for a prescription of it. The Lilly who makes it, if you have a drug rep, they actually do offer vouchers. I know it's very beneficial for our Medicare patients, because theirs is going to be quite expensive, and they kind of hand those out very frequently. So if you can get in contact with them, I try to hoard those for my Medicare patients. because the commercial side usually does cover it pretty good.
I tell people too, if you have a family member that's having a low and you don't have the injection kit and the person cannot chew on the glucagon tablets, I simply tell them to get those cake gel decorators to decorate cookies and cakes with, like over the counter at Walmart. Or, at Walmart, they're like $2 or something, and carry them with you. They don't go bad, and you simply just twist off the cap, and a family member just squirts it into the side of your mouth. That way, they don't aspirate because they're really not chewing much, and it gets absorbed really quickly in their mucosa.
I think I missed something on this slide. No. Okay. Okay, so strategies to prevent the low sugars, educate on meds and behaviors, relax the glucose targets in the short term, maybe up for a few weeks even. Revise your A1C targets, increase your frequency of monitoring, and consider continuous glucose monitoring systems. And different goals are going to be based on age, comorbidities, and the functional status of the patient. So glucometers, I found a lot of different variety of how often do you update those, but I kind of erred on the side of caution, and what I took from it was maybe every 2 or 3 years to review.
And insurances will usually pay for a new one every year.
Okay. So educate them how to use it properly. A lot of times they don't even have the date or time set correctly, so just make sure they know what to do. And even if they're using a glucometer and they come into your clinic and we can download the information from the pump or scroll through it, I think it's always like a really good idea to have them still document their sugars on log sheets, because it makes them make associations with what the sugars are and what happened prior to that, and it helps make behavior changes. So the continuous glucose monitoring, we have a couple different systems. One is called the Guardian, and one brand is also called Dexcom. So either or any of those, one or both of those can be used with pump systems, and some can be used as standalone systems. And then we have the newer version, the Freestyle Libre. It's actually a glucometer system that it's attached to the arm. You change it out every 14 days or 10 days, and it actually allows you to just scan over it and get a reading, and as opposed to the Dexcom or Guardian that actually will alarm you on low, and if it's working with the pump, sometimes it'll auto suspend on low if you're not making a change. So those CGMs are not as accurate as finger sticks or blood draws, but it's still a good option, especially if they don't have awareness of lows. At least this is catching them before they get to that point. So I'm going to walk up to this camera again. So this is called the Guardian. See how little it is? That's a CGM, or the Guardian Continuous Glucose Monitor. Is very tiny, attaches to the skin. This one they change out once a week. And then I just put this this is the Freestyle Libre. This is it doesn't have the capabilities of Dexcom or Guardian, but it is a nice option, if they're having hypoglycemia or they don't want to take the time to stop at work and check their sugar with their glucometer, they can just quickly scan over their arm with it. Cherie will tell you this though, most times it's not going to be covered unless they actually document in the chart that they're checking 4 times a day. So like I just had a patient yesterday, very non-compliant, but just sick of diabetes, sick of checking sugar, sick of dealing with it. So we're trying to get him the system. Well, what we're going to do is have him check 4 times a day and get those to me in a week, so if we can try to get them covered for the monitor. Okay, so the emergency kit, this is kind of the thing I came up with a while ago when I started working here. So the worst thing is the patient's maybe not not prepared for low sugars. So I often will tell them to get a Tupperware container that's plastic and see-through that they can write on there for hypoglycemia treatment. And I tell them to stick in this container anything that you can use to treat, like with the simple carbohydrate to treat hypoglycemia. So it's a go-to for them. So they're not just grabbing everything in the pantry and then getting rebound hyperglycemia. Now they've got readily available simple sugars. Of course, you want to make sure they wear medical alert identification. I mean, I've seen them as cheap as like $10 on Amazon. So they can get the bands that look like those Lance Armstrong bands and lots of more expensive varieties too. So complex carbs, you want to make sure they're after a reversal of a low sugar, they're treating with a carb with a protein source, or, you know, a complex carb like whole grains, yogurt, peanut butter crackers, something so that they're following it so they're not dropping out again. So of course, patient education is the key thing here. Know your risk factors for lows, know how the meds work, the dosing, the administration. Remember, adding new agents may mean decreasing others. More frequent monitoring, documenting, communicating sugars is important. Determining triggers, and the thing they sometimes don't do is make the association of why. You know, so sometimes tell them on the log sheet, if you have a low, just make a note on there, like what went on that day, because a month from now, they usually don't remember. So we want to correct that problem, make sure we follow up, make sure they're prepared for lows. And that's all I got, guys. If you have any questions?
Hi, this is Jennifer again. I have a question. It's a little bit tangential to this. Thanks for the presentation. It was really good. In there, you mentioned that something that makes people at risk for hypoglycemia is a low carbohydrate, high fat meal. And it may be beyond the scope of what we can talk about today, but I'm just curious about the role of dietary fat in the regulation of in glycemic control. I have one patient who says that a high fat meal, if the carbohydrate content is equal, say, so let's say a pizza compared to spaghetti with just tomato sauce, that the high fat will keep her sugar up for a lot longer. And I just wondered if that's scientific.
So fat, it reduces you don't absorb as quickly with high fat content meals. So let's say they had a really high fat, like say your pizza, and they treat it, with their insulin or whatever. And then, the sugar, they may feel like it's not being absorbed quickly, so they may eat more. And then the sugar then will go up because one, they ate their extra intake because they didn't feel it was going up enough or it was getting low. And then the carbs from the high fat content meal start getting absorbed. So then you have down the road more hyperglycemia. So in the short term, like right after a meal, sometimes they just might not absorb it. And that's why usually I tell patients, like they'll tell me, well, when I got a low, I ate a big fat candy bar. Well, how'd that work for you? Well, next time I checked my sugar, it was like 400. It's because they had to treat several times to actually get it up quickly enough. And then they start absorbing the carbs from the fat, from the candy bar.
So how do you dose insulin in somebody in that kind of situation? If they're going to eat a high-fat meal, they would take less immediately at the time of the meal and then just check later after a high-fat meal, would you say?
So I would probably maybe cut down a little bit initially. I mean, it depends on what they're on. Like if they're on a pump, that makes it sometimes a little easier because they can give part of the dose initially and then give a little more of the dose later on. Mm-hmm. But I mean, the best thing is like to get ahead of it and try to avoid those really high fat meals. But also at the same time, maybe if they're not truly hypoglycemic by finger sticks, quickly after they eat it, try not to double up on the carb intake in between.
Right. Gotcha. Okay. Very helpful. Thank you.
Yep.
Are there any other questions? We have about 10 minutes left. And thank you, Renee, so much for that. That was great.
Sure. Thank you.
Hi there. This is Joseph. I did have a question.
Sure.
So I was wondering what you do for patients who feel subjectively hypoglycemic at more of a normal blood sugar range and how you manage that.
So I think what I find usually is if they're starting out high, really high to begin with, like say they're 400, they drop down to 100, but they feel hypoglycemic. It's just because of the quick change from one point to the next. And a lot of times it's just letting them acclimate to the improvement in blood sugars. So I wouldn't, unless they're continuing to trend down, I wouldn't treat that with simple carbs, but I would just tell them it's just a matter of acclimating to improvement in the readings.
Thank you.
Sure.
Dr. Rexroad, did you have a question? You might be muted.
I was just going to make a comment going back to the case, or to the presentation earlier, the case. We saw a lady right before lunch who actually is allergic to metformin. She broke out, got hives, all of that. And then she had a thyroid tumor on Victoza. So we've been trying to look at options for this poor woman. Actually, we ended up starting her on insulin today.
Okay.
But she's very motivated. She exercises, does all the things she's supposed to do, and then she keeps having these bad luck things with the agents.
Oh, poor lady. So the whole thing with the GLP-1 agonists, you know, the black box warning for medullary thyroid cancer. So it's extremely rare. I mean, I'm sure you probably know this, but it actually was found in rats only, given like 7 times the human dose. So it's very high dose dependent, and not even in any human studies. So if I had a patient with maybe a thyroid nodule, I mean, not saying it's not possible, but they have never had thyroid cancer and no family history of medullary thyroid cancer or multiple endocrine neoplasia or MEN type syndromes, you know, I probably would still give it, with the idea of if this nodule is big enough, I would probably do an ultrasound just to make sure, you know, and you could always biopsy it. But I guess at first when these agents came out and the warning was there, I was very reluctant to give the medication. But as I guess I've found over the years that it's so rare to have that be there. I mean, you still have to review the black box warning with the patient, but it's not that I would, on every patient, I wouldn't necessarily avoid it if they have a known thyroid nodule that looks on ultrasound not real concerning.
Hers actually turned out to be a Hurley cell tumor.
Was it malignant though?
Low-grade malignant, I believe. It wasn't a medullary adenocarcinoma or whatever, but she doesn't want to take anything like that again, and I don't blame her.
No, I could completely understand that. So in that case, why put her through any undue stress?
Yeah.
But yeah, it sounds unfortunate that she's not been able to take the things you want to give her.
Yeah.
All right, guys. If there aren't any other questions, we can adjourn a little bit early. Thank you again, Quentin, for the case, and thank you, Renee, I'm sorry, for the presentation. Our next session is the 27th of the month,
Okay.
and we can accept.
Thank you.
Yeah.
Thank you, everybody.
Thank you very much.
Hey, Caitlin, I had a question.
Yeah, absolutely.
Has anybody presented on the different types of diabetes? You know?
No, they haven't. At the last session, we got into an impromptu discussion about it because a patient came up who was theoretically 1.5 diabetic.
Uh-huh.
But it was just a short discussion. So no, we haven't had that presentation.
Okay. Is it possible, because I have to do the next one this month, if we could have a list of what was already presented, because I don't want to duplicate anything. Would that be possible?
Yeah, absolutely.
Okay, thank you.
Yeah, no problem. I'll send that to you after this.
Okay, thank you, everybody.
Thank you.
What did I do just there?